Yeah, you can start.
Good evening, everyone. I welcome you all to the ICRI teaching program. I request Dr. Sikandar sir to kindly begin the proceeding. Over to you, sir.
Good evening and welcome back everyone to our recap session of women's imaging. And today is our last session of recap session of this. And we have one of very important topic, that is gynecological malignancies by Dr. Palak Popat. Apologizing for the delay because there is some technical issue with the Dr. Palak Popat. She will be joining very shortly in 2-3 minutes. By the time I request all the attendees, we have a couple of announcements from our ICRI side of upcoming events. So, coming Sunday, we are having two sessions. Please make a note. We have two sessions. Our routine fetal radiology session, which is in the morning, that is scheduled at 9:30, and it will be getting over at around 130. So this is the stuff related with the fetal radiology, and again, it is more focused with the various aspects of our fetal, that is perinatal and maternal mortality, then pre-eclampsia screening, then approach to fetal renal anomalies and fetal brain anomalies, then again fetal interventions, then color Doppler, how the fetal growth restriction perspective is there, then what we have achieved, something related with the samrakshan highlights related with the fetal radiology. So this is in relation with the fetal radiology, and we know that we have covered almost all the fetal radiology stuff till date, and this is will be the last session of this current tenure of the office bearers, so including me. And then next February onwards, it will be little redefined in a different way, so that will keep you updated. Now, another session in the evening, coming Sunday, is we have a synergy series. Actually, this synergy series was supposed to happen on the first Sunday, as our first Sunday is always a synergy series day. But since we are collaborating with the Canadian University, and 1st January means it is like New Year and all that, so majority of faculties are not available in Canada. So that was the reason this was rescheduled to the third Sunday. So third Sunday, we are having an exciting stuff. This is something related with the clinico-radiological correlation. Please make a note. And there are different things related with the vascular imaging, that is acute stroke imaging. Then you have imaging of post CVA, that is neuro imaging. Then again, neuro oncology primer, clinical and imaging pearls is there. Then if next one is common soft tissue and bone tumors, an orthopedic oncology perspective. So it is something related with the onco MSK stuff. And last we have mammography, yesterday and today, something very fascinating stuff, because we know how the revolution of the technology has happened and is still happening in our radiology, and it is one of the fastest growing speciality in all our medicine, that is radiology. So it's like a computer science. Every week or every month, something new stuff, new vendor, new machine, new protocols are being set by the different companies. So that is one of the thing where you need to understand where we were and what we will be. So that is related with our coming Sunday's program, and that is on third Sunday. Fourth Sunday, and I forgot actually, this third Sunday, the morning session is available to our subscribed attendees. That is, whatever whosoever is I subscribe to our ICI teaching programs will be able to attend that session. But evening session is free for all our IRA members. Only IRA members, even though you are not subscribed to ICRI teaching program, can be accessible for the evening University of Masters program of Canada. So please make a note, two different programs, two different links will be there. One is in the morning with subscription, one in the afternoon, evening will be with the mm, free for all our IRA members. Then coming to fourth Sunday, we are having a special same mock exam session. So this time we have scheduled again on pediatric radiology based on the request of many attendees. Somewhere pediatric radiology and that too with the conventional imaging is very difficult and very uh, overlapping actually, because all of them or majority of the stuff or few conditions they look similar. Like for example, you have meconium or versus any GI pathology, so they look similar. So that was one of the reason there were a lot of requests to have a pediatric radiology session. So the mock session will be based on the pediatric radiology. And I request all the residents who are joined today, who are third year, who are final year exam going candidates, please, if you are interested, please do take part in this mock exam where you will be having a mock session and you will be live. Cases will be given to you as if it is an exam. So anybody interested, please do write to icri74@gmail.com or can contact any of our office bearers, so that we'll try to get you on board. This is related with the fourth Sunday. Now coming to fifth Sunday, we have 5 Sundays in January. So the last Sunday, again we have exciting stuff related with the MICR exam. So we have planned entire Sunday for MICR exam. And again, that MICR session will be free for all our IRA members only. So if somebody is not a member, please do become a member, because becoming a member, lot of privileges are there. Not only you can attend couple of ICRI sessions, but all the IRA related events, conferences, CMEs, there will be always reduced registration fees for the IRA members. And lot of things are there for IRA members. You can visit our website, that is ira.org.in. So this MICR stuff will be covering all the entire part one, part two, part three. So we know that part one is comprising of anatomy and physics, and then part two, A and 2B are there two different exams, and part three is another third part of this exam. So we have already finished one entire cycle of this exam, and those who are appearing, those who want to appear right from the part one, please don't miss this session, because you will know exactly what is the format of this exam, how the examination is going to happen, and accordingly you can prepare it. So this is important for this MICR session. So it doesn't mean, another reason is it doesn't mean that only those who are interested in MICR exam can appear, but those who are interested in appearing for FRCR exam, because the pattern of MICR is near about similar. The question pattern, the questions, the answers format is mostly similar to the FRCR exam. And again, this is not only important for FRCR exam because there will be cases, there will be discussion on physics, anatomy, clinical scenarios, images, differentials, and further line of management or further line of investigation. So this is definitely helpful for all our Indian exams like MD, DMRD, DMRE, and even for our any fellowship exams where we will be conducting. So already our ICRI fellowship is started. Now regarding ICRI fellowship, so we have we will shortly give the notification for the ICRI fellowships for the candidates who want to apply for the fellowships, because already institutional notification is done and we are in the process to finalize the institutions. And once the institutions are finalized, parallelly we will be circulating the registration process for the FICR exam, that is fellowship of ICRI exam. So that will be scheduled on in February 2nd or 3rd Sunday. And I think Dr. Palak has joined. So just one more announcement. So 12th, the day before, day after, like on 12th Thursday evening, we will be having a semi-final of our national IRA quiz online. So it is again an exciting stuff in the evening. So if somebody is interested, please do attend that session, because a lot of cases, again, it has anatomy, physics, and various clinical scenarios. And the final top 5 teams will be competing at Amritsar live on site in the Amritsar conference. So these are a couple of announcements. So with this, I welcome our today's faculty, Dr. Palak, and I welcome our today's moderator, Dr. Ekta. So again, once again, apologizing due to some technical glitch, we are delayed today. And without taking much time, I hand over session to Dr. Ekta. Over to you, Dr. Ekta.
Thank you, sir. Good evening, everyone. So without delaying further, I'll just uh, start with, is my screen visible? Yeah. So we have Dr. Palak now. Dr. Palak needs no introduction. She's a great friend and she's great academician, associate professor in radiology in TMH with special interest in women oncoimaging. She has many publications and many book chapters to her credit. Ma'am, please, over to you.
Yes. Yeah, am I audible?
Yes, ma'am, but your voice is breaking. Maybe you can put off the video so that
Yes,
the
let's do
stream
that.
moves, yeah.
1 minute. Am I audible better now than before?
Yes, yes.
Okay.
Is it okay if we go, Janvi, without the video?
Yeah, no problem. Absolutely.
Thank you,
no
sir.
problem.
Thank you.
Yeah.
Sir.
Please continue.
Okay. Is my screen shared?
Ma'am, screen is visible, but there are breaks in your voice, ma'am.
Uh, Can you hear me?
Yes, ma'am. Now we can hear you.
Okay. No, somehow there is some technical glitch. The system is not responding.
Ma'am, can you please stop sharing and start it again?
Okay, let me try that.
I think, ma'am, you'll have to restart your system. It is not at all showing anything.
Ma'am, I stopped sharing from my end. Can you please start it again, ma'am?
Yeah, sure. I'll just join.
Hello.
Yes, sir, we can hear you, sir.
Yeah.
Yes.
Can I go live?
Yeah.
Ma'am, right?
Yes, sir, please, sir.
Oh,
So we have faced some technical error with Dr. Palak's connection, and Dr. Sikandar has kindly agreed to show some of his cases. Please, sir.
Thank you. Good evening, everyone, and sorry for the delay. Until the time, since our topic is gynecological malignancies, so I have a couple of cases pertaining to the gynecological malignancies in different scenarios. So I will just directly go to the cases. Yeah. So there are different applications which we will be using in different gynecological malignancies. We know it is a blend. You have, for example, this is a pelvis PET CT. Pelvis means we don't do pelvis PET CT. These are the cross-sectional images of the CT. Then you have PET image. Then you have fused PET and CT images. And this is a whole body PET image which shows there is some sort of focal activity here. But the important here is, if you see this, so it is like some sort of a cyst or some sort of a dominant follicle which you will see. And but the cyst usually will have a thin regular walls with no enhancement actually. Or unless and until the cyst is infected or the wall is infected, then only there will be a focal area of uptake which will be seen in the ovarian cyst. So here right ovary looks normal. This is right ovary, and uterus absolutely normal. This is a bubble uptake which is seen here. And this looks like some sort of an uptake which is involving the left ovary walls of the ovary. So what do you think about that? The simple thing is it was a dominant follicle with some sort of a PID related symptom. So that looks, that is one of the reasons you have to see. But most important, you have to differentiate it from the very tricky ovarian malignancies where the cyst is very small, and then you cannot differentiate whether it is a complex cyst, infected cyst, or it is a very small ovarian cystic lesions like cystadenoma or cystadenocarcinoma. So that is one aspect. Now coming to another case, you have another case here. So this is a multiloculated cystic lesion in the right adnexa. So this is a CT image. You can see faint, thin septa which are seen here. And this is a bubble uptake which you are able to see. This is a bubble filled with the oral contrast. So this is a PET image, and these are the fused PET and CT images. But if you concentrate, our area of focus is on the right adnexal, that is cystic lesion. So here again, the cystic lesion is not showing any amount of uptake. Now the problem with this is we will clearly, as far as the PET and FDG, so these are all FDG radio tracer I am showing. So this FDG radio tracer is not highly sensitive for various malignancies as well as various pathologies. But in the case of ovarian lesions or ovarian neoplasms, again, it is a notorious, because any sort of cystic lesion with very minimal soft tissue or no soft tissue, here there is practically no soft tissue, but septa are there. So it can be a complex cyst. So how you are going to differentiate with the complex cyst and the cystadenoma versus cystic neoplastic lesions of the ovary? It is little tricky. But as far as the major or the general dictum is no uptake, obviously it is a benign entity. Uptake, it is a malignant entity. But there are issues related with the cystic lesions with the FDG. You have similar problems with the cystic lesions in pancreas also, or cystic RCC you are able to see, where you cannot find any significant amount of uptake in the lesion. So these are very important aspects. So it turned out to be a complex cyst actually. So complex cyst without any neoplasm or any malignancies. Now coming to this third lesion, you have a uterus and you have endometrial fluid. Sometimes what happens, the endometrium is thickened, or sometimes you have a thinned out endometrium, or in situ endometrial carcinoma, you have suspecting patient is presenting with a PV bleeding, having a menorrhagia or dysmenorrhea, then clinically background, it comes to us first and foremost is ultrasound, where you will be evaluating it, and then later any suspicious or any sort of cervical biopsy, then probably it land up with the PET. But if you see here, there is clearly a fluid which is seen in the endometrial cavity, and the uterus looks like menopausal. So post-menopausal uterus, and this is the whole body scan which is seen, and these are the bowel uptake which is seen in the entire whole body scan, and this is a bowel uptake which is seen in the pure PET images. These are CT images, and these are the fused images which are able to see. So here no significant amount of activity. So endometrial analysis is also equally important. Just let me know when Dr. Palak joins so that I can stop there.
Sir, ma'am is here, sir.
Okay. So if
She
she's
has
ready,
joined
then
and she
she can.
left again, sir.
She's not there now.
No, sir. I'll try to call her.
Okay. So I will continue. The moment she is stable and her system is stable, then probably you let me know. You can interrupt me at any point. So
Sure,
till
sir.
that I have cases, I will just go with the gynecological malignancies.
Yeah, okay.
Yeah. So this is another case now. It was a post-operative carcinoma endometrium with splenic metastasis, something very rare. If you see the spleen, usually splenic metastasis is not common. But here, appearance of a splenic metastasis obviously looks like something we are not used to it. We know liver metastasis is very common. You have adrenal metastasis, you have nodal metastasis, skeletal, lung, brain, and soft tissue metastasis. But splenic metastasis is something which we need to be very, very careful, because we have to rule out or we have to diagnose. So this was a splenic metastasis, very uncommon. This was a post-operative case which came for the post-operative further evaluation, and spleen shows this sort of a lesion which was irregular. Probably it doesn't look like a cystic lesion, it doesn't look like an abscess, and it was something suspicious. And for the grounds of the suspicious, it was referred for the PET CT, and this PET also shows the multiple nodular lesions which are able to see, and there is a mild amount of splenomegaly as well. So they are not cystic lesions, they are solid lesions, hypodense with significant amount of uptake, which is corresponding with the spleen. So this is like something turned out to and confirmed with the endometrial carcinoma. But secondary to endometrial carcinoma, it can be metachronous, and it can be solitary, or it can be limited to the parenchyma, or it can be metachronous, as has been seen in this case. But remember, don't always make a point that spleen doesn't metastasis. So only lymphoma is involved in the spleen. So it's not like that. So now another case of clinical history of menorrhagia. Now simple. So menorrhagia, postmenopausal woman, obviously you have to think there is something wrong. So any evaluation gynecological, whether it is ultrasound, CT, MR, or PET, we have to focus first and foremost thing, you have to rule out the malignancy. And the most common pathology is not malignancy. The cause of menorrhagia, most of the time we see it is a fibroid or some sort of endometrial hyperplasia, endometriosis, or endometrial polyp, or something related, just bulky uterus. So these are many varied things which we see in ultrasound, and this case was showing thickened endometrium. And histopathologically, it was a carcinoma endometrium diagnosed, and PET was advised for staging the based on the clinical history. Now, if you see this, this is a CT image of the endometrium. You see the uterus, the amount of enhancement. Usually the myometrium, endometrium interface will be very clear. There won't be much uptake in the CT as we have seen. But these are the fused images which show significant amount of uptake, which is seen here. And these are the PET images, again, significant amount of uptake. But most important, if you see, there are multiple nodes which are seen here in the abdomen. So plus peritoneal nodules. So this is menorrhagia clinically, thickened endometrium ultrasound wise, histopathology carcinoma endometrium, and on PET CT you have a primary lesion with metastasis to the nodes as well as to the peritoneum. So, but supradiaphragmatic region is not inward. So the role of PET in these scenarios will be for the evaluation of the staging also. So infradiaphragmatic pathology with peritoneal, nodal, and probably local parametrial infiltration in this case. So these are the things which you should always remember when you are analyzing with the PET. PET is not as highly as sensitive like you see MR soft tissue resolution, perivesical or pericervical, fat standing, fat streaking, thin peritoneal nodules, thickening, sorry, and small peritoneal nodules. So these are different varied pathologies which we are seeing. Sorry, I went back. Now, another case that is a post-operative carcinoma ovary. Now, you know ovary. What are the regions of involvement? The most and commonest involvement of the ovary is the nodes. Then you have peritoneal. Then you have omental involvement. So this is a diffuse peritoneal and omental thickening with nodularities and omental cakes and all that what you see. So with a significant amount of ascites also. So these are the axial sections what we have seen and highlighted at this case. So this is like usually PET is always a whole body. Don't get confused actually. So this was only the selected images which were seen in the CT. These are the fused PET and CT images, and these are the purely PET images. Now another thing which is something which we know, that is like, you know what is Krukenberg's tumor. So it is a diagnosed Krukenberg's tumor where the PET CT for staging has been done. So there is a mild amount of uptake which is seen in ovarian lesions, and this is a SU max which is seen. So very subtle, like this is a lesion, this is a cystic ovarian lesion with surrounding subtle soft tissue which is seen in the periphery and associated node in the left para-aortic region. So this is also notorious because don't go always by the SU max. SU max is something misguiding if it is on the lesser side as well as on the higher side, because higher side nowadays there are a lot of applications which are being used for the neoplastic, and it turned out to be some sort of an infection or inflammatory lesion in that particular region. Now, what is the fun of PET actually? If you see this image, probably if you, unless and until you have a multi-slice CT, you have a reconstruction parameters or reconstructions in your institutes are done at a very small interval, like you have 1 mm or 2 mm. Then, and another most important thing is you have to follow that particular thing in a continuity. Then only you will be able to see whether it is a vessel, endon of a vessel, or is it a peritoneal nodule. But if you are having, yeah.
Sorry to interrupt you, sir. Palak ma'am is here, sir.
Yeah, with this case, I'll just finish it off.
Sure,
So small, tiny peritoneal nodule. So single section or your machine, you are not doing a recon, or you are doing a recon of 5 mm or something above, then probably you will miss any sort of a tiny nodule is there. So this was a tiny nodule which is showing an uptake. So these are the fused images, and this is a purely PET image. So that is where the role of PET and the sensitivity of PET. But again, I'm not telling a very small nodule can be seen. Usually, a lot of literature is showing that nodule which is less than